Welcome to this explainer, where we're going to unpack the clinical realities of what actually happens when a tooth extraction doesn't go exactly according to plan. I'm really thrilled to guide you through this today, because as any dental practitioner will readily tell you, actually removing the tooth, well, that's often just the beginning of the story.
So what happens when a routine extraction goes wrong? We're going to investigate the physiological mysteries of post-extraction complications, literally from the immediate, stressful aftermath right there in the dental chair all the way to delayed healing that might show up weeks later. We often think of pulling a tooth as a super simple in-and-out procedure, but the human mouth is a wildly complex, highly vascular, and incredibly bacteria-rich environment. And when things go wrong in there, they can go wrong in some truly fascinating and, sometimes alarming ways.
In this explainer, we'll navigate the strict timeline of these events. On our agenda, we've got 1. Bleeding. When to worry. 2. The dreaded dry socket. 3. Fractures during extraction. 4. Sinus communications explained. And 5. Severe bone complications.
All right, let's dive right in with Section 1. Bleeding. When to worry. Managing immediate post-extraction hemorrhage. Okay, looking at the immediate hours right after a tooth is pulled, it's absolutely vital to know when bleeding crosses that line from totally normal to actually dangerous. It is entirely normal to see bleeding for the first 30 minutes. That's just the body doing its thing, waiting for a healthy clot to form. And seeing a little blood-stained saliva, that can safely last for up to 8 hours post-extraction. But here's the crucial point. Any bleeding that lasts longer than 12 hours is officially abnormal. If a patient is forming a large hematoma, which is essentially a pooling of blood in the soft tissues of the mouth, or if the blood loss is so severe they actually need a transfusion or a trip to the ER, well, we have a major complication on our hands. This kind of intense bleeding is often driven by underlying risk factors, like coagulation disorders, antiplatelet medications, or bleeding deep within the bone.
So how exactly do we stop it? To halt intense bleeding, practitioners use a highly structured, stepped management protocol. Step 1 is beautifully simple. 10 minutes of firm pressure with a damp gauze to encourage that clot to form. If that doesn't do the trick, we escalate to Step 2. This involves packing the socket with a hemostatic agent like Surgicel and actively suturing it in place to really lock it down. You might also introduce a tranexamic acid mouthwash right here. Now, if the bleeding is just stubbornly intense, we move to Step 3, administering local anesthetic with a vasoconstrictor to temporarily clamp down those blood vessels, followed by applying bone wax directly over the bleeding bone, or even using chemical or electrocautery to seal it.
Let's move on to Section 2, the dreaded dry socket, unpacking alveolar osteitis.
Fast forward 1 to 3 days on our timeline, and we encounter a totally different beast. Clinically defined as alveolar osteitis, this excruciating medical mystery is essentially a biological failure. It presents with this increasingly severe radiating facial pain and a very distinct halitosis, or bad breath. Why? Well, remember that protective initial blood clot we just talked about? It's completely gone. It's either been physically dislodged or it broke down prematurely, and that leaves the bare alveolar bone totally exposed to the oral cavity. When you look at the extraction site, there's just an empty socket with zero visible blood clot, and often, food gets packed right into the bare bone, driving a super intense inflammatory response at the gum line.
Now, as you can see in this chart, a dry socket occurs in merely 3% of all routine extractions. But check out that second slice. That risk literally skyrockets to a staggering 30% when we're talking about extracting impacted mandibular third molars, better known as lower wisdom teeth. That is a massive jump, and it really highlights just how anatomically challenging and traumatic those specific extractions can be.
The probability of getting a dry socket heavily increases with a few specific risk factors. Smoking and oral contraceptive use, those are major red flags, right alongside female gender, excessive trauma during the extraction itself, or lingering bacterial and bone fragments left in the socket. Management here is totally targeted at soothing that exposed bone. Practitioners will perform copious irrigation with saline or chlorhexidine to flush out all the food debris and bacteria. Then they'll pack a specialized soothing dressing, like Alvogel, directly into the socket. This immediately soothes the area, physically blocks any more food from packing in there, and crucially buys the body time to encourage proper epithelial healing.
Which brings us to Section 3, fractures during extraction, structural damage in the chair. Let's actually rewind back from the healing phase to the procedure itself. Put yourself right back in the dental chair. What does it mean if the operator is applying force and suddenly hears a loud crack? A sudden crack, paired with a completely unexpected looseness of the tooth's top portion, almost universally indicates a root fracture. It's a highly stressful complication for everyone involved. When the top of the tooth comes out, you look down, and the roots are just missing, left behind in the socket. This happens because of factors working directly against a practitioner: exceptionally thin roots, super dense surrounding bone, teeth that are heavily weakened by decay, or frankly, excessive luxation force.
If the clinical situation demands that the fragment absolutely must be removed, like say to make way for a dental implant or to prevent further pathology, the operator has a clear pathway to follow. Step 1, they'll methodically start with careful luxation, specifically using specialized tools like Coupland's and Cryer's elevators, to delicately work around the root. If that works, Step 2 is escalating to root forceps to pull it out. But if that fragment stubbornly refuses to budge, we have to move to Step 3, a surgical approach. This means physically raising a tissue flap and actively removing the surrounding bone, which often requires a referral out to a specialist oral surgery service.
But hey, roots aren't the only things that can break. Even more alarming, though thankfully quite rare at an incidence of just about 0.08 to 0.15% of simple extractions, is fracturing the maxillary tuberosity. This is the bony area right at the very back of the upper jaw, and it happens to be the weakest area of bone in the entire maxilla.
So, why on earth does the jawbone break here? It's heavily linked to anatomical vulnerabilities. If a patient has a large maxillary sinus that dips down and hollows out the tuberosity, that bone becomes incredibly fragile. Combine that hollowed bone with a lone standing molar that's been bearing the brunt of all the bite force, or a tooth suffering from hypersumentosis, where the root literally fuses to the bone and the risk just spikes. If an operator feels a sudden increase in mobility of the entire tuberosity region, they must halt the procedure immediately. You absolutely cannot just twist the tooth out, or you risk tearing the mucous membrane and the greater palatine artery, which leads to severe blood loss. Instead, a rigid splint has to be placed to stabilize the fracture for a full 4 to 6 weeks to allow for bony healing before they can even attempt the extraction surgically.
Section 4. Sinus communications explained, bridging the oral cavity and the maxillary sinus.
That precise anatomical vulnerability of the upper jaw we just talked about, specifically the large sinus cavity sitting directly above the roots of our upper teeth, leads us right to our next complication. When a tooth is removed and a hole is accidentally punched straight through the floor of the sinus, some really fascinating symptoms emerge. A patient might unexpectedly complain that liquids they drink are regurgitating straight out through their nose, or maybe they can't suck through a straw anymore. Clinically, practitioners use something called the fog test. If a dental mirror is placed near the empty socket and it fogs up when the patient breathes, or if there's a distinct whistling sound heard on exhalation, a pathological pathway between the mouth and the sinus has definitely been created.
Terminology is literally everything here. We've got to carefully distinguish between an immediate OAC, an oroantral communication, and an OAF, an oroantral fistula. An OAC is the immediate open hole created the very second the tooth is pulled. But if that hole is left untreated for just 48 to 72 hours, the body tries to fix it by lining it with skin-like tissue. This creates a permanent epithelialized tunnel, the OAF, which stubbornly presents 7 or more days later, often bringing along sinusitis and purulent discharge.
Managing an open sinus requires absolute, strict compliance from the patient. To prevent a massive pressure buildup that could literally blow the delicate healing clot right out of the socket, patients are instructed to absolutely not blow their nose for 2 full weeks and to always sneeze with their mouth open. For tiny defects, that alone might do the trick. But for defects larger than 2 millimeters, the patient might need to wear a continuous suck-down splint for 7 days. And if the defect is really large, or an epithelialized fistula has already managed to form, surgical intervention is mandatory, often utilizing a buccal advancement flap to physically pull tissue over the hole and close the pathway for good.
Finally, Section 5, severe bone complications, systemic impacts on jaw healing. To wrap things up, we must examine the most severe systemic complications that can pop up long after the extraction site was supposed to be completely healed. This is where dental extractions intersect with a patient's major medical history. We are looking at MRONJ and ORN. Both of these conditions are truly devastating. They result in catastrophic bone destruction in areas of dead, exposed jawbone inside the mouth. Clinically, they look incredibly similar, but they stem from completely different systemic causes. MRONJ, medication-related osteonecrosis of the jaw, is triggered by powerful drugs used in cancer management, specifically anti-angiogenic or anti-resorptive drugs like bisphosphonates. ORN, osteoradionecrosis, on the other hand, is a direct result of a history of targeted radiotherapy to the head and neck region, which permanently damages the blood supply to the bone itself.
Because these underlying conditions so severely compromise the jawbone's fundamental ability to heal and remodel, simply pulling a tooth can trigger a massive, non-healing necrotic cascade. Therefore, as this slide points out, any extraction for an at-risk patient absolutely must be vigorously weighed against alternative dental treatments. If an extraction is genuinely unavoidable, it demands an immediate referral to a specialist oral and maxillofacial surgery department. Because at this point, we are no longer just dealing with a localized socket, we are dealing with a deeply compromised systemic physiology.
And that brings us to the end of our timeline. As we review these post-extraction complications together, progressing from simple localized bleeding protocols and dry sockets, up to structural jaw fractures and breached sinuses, and finally hitting on catastrophic systemic bone necrosis, it leaves us with one critical, highly provocative question to always keep in mind. When we sit a patient down in that chair, are we treating just the tooth, or are we treating the whole patient? Thank you so much for joining me on this explainer. I really hope this deep dive into the clinical reality of extractions gives you a brand new appreciation for the incredible complexities of oral healing. See you next time.